All right, are you there, Dr. Eccles?
Okay, I am back. Let me check my phone and see. I don't know what's going on. Where is everybody? I know we have a couple of.
You see, it looks like there's six attendees here. I can't tell who they are, but let me just write in the chat pod here.
Attendees. Oh, okay. Okay, you can go ahead and get started then.
Okay. So I wanted to.
I know there's two more that's going to join us. There's going to be two more joining us, and they're a little bit behind. They're finishing up on their last patient, but you can go ahead and get started.
Okay. So the only things I had prepared for today, I don't think we finished through all the hepatitis C stuff. So I wanted to get more to some of the aspects about treatment of hepatitis C, and then I know the last couple of times there were multiple questions about syphilis and how to treat other STDs. So I've got some slides to kind of run through that stuff and reinforce that. Syphilis is something that's really confusing. It's a very complicated disease, and you actually have to, stage it first of all so you know where to treat or how long to treat for. So, but I also wanted to leave plenty of time during the hour for case presentations if there's any questions. So, Dr. Eccles, do you think right off the bat there's any questions that you wanted to, or any cases you wanted to run by me?
Dr. Webb, don't you have a case that you recently, I think he's on mute. Dr. Webb had a case yesterday, or a patient came in today, a new diagnosis of HIV. We sent all her viral load, we sent her genotype viral load off. I don't know if he has any questions about her, but that's the last case I was told about recently.
Okay. Dr. Webb, are you on audio there? Can you maybe unmute yourself?
Can you hear me now?
Yes, we can. Why don't you go ahead?
Okay. We had a lady who was incarcerated, and she was found to be HIV positive. We're just getting her worked up. We submitted, as a matter of fact, the Western blot today to confirm and to get we also submitted the genotype and the CD4 cell count. We started her, however, on Complera anyway. The other thing was she had a large boil on the lateral side of her neck, so just to be on the safe side, she's been placed on Bactrim, 400 milligrams BID. And what I wanted to ask you, when you look at these patients that you have no idea about and you're looking at immunizations for them, do you go ahead and get titers if they don't have a shot record or something, or do you just arbitrarily repeat immunizations?
That's a really good question.
Not arbitrarily. I know you don't give live virus, but I mean otherwise.
That's right. That's right. So we can get into immunizations in just a sec. I wanted to ask you a couple more clarifying questions. Do you know anything about this woman's past history? Has she ever been treated before for HIV or ever had a T-cell count in the past?
No. She was in jail when they diagnosed her. We don't know what her T-cell count was in the past, so we're kind of shooting blind on this lady. We're trying to work up as rapidly as we can to get all that information.
Yeah.
Did they give her any medicine while she was incarcerated, Dr. Webb? Did they start on anything like a Tripla or Complera or anything like that?
They never did start on anything, and so far what we have, the RNA was 55,000 copies of the virus. That's all the information I have in my hand. That's what I inherited. But no, to my knowledge, she's never been treated with anything.
Okay, so there's a really important point here that you know, in order to start somebody on treatment, you really need to know what their treatment history is, and I feel for you because very often you are flying blind. Even if somebody's had prior care, for example, in a different city or something. I mean, in San Diego, I see people that have been all over the country, and they just kind of end up here. And it's like, oh, well, I saw a doctor in Florida for a while, and then in North Dakota, and so on and so forth. And sometimes it's really hard to even get the records when they've been in care before. But there's a really important reason why you should try to find those records if they exist. And that is that what you're worried about is somebody's risk of having a virus that's resistant to some of the drugs. So just like with any bacterial infection, you know, a viral infection, you can have drug resistance that builds up, and that's why that genotype is so important. Now, there's a little bit of debate in this area about whether you should wait for the genotype to come back first or whether you should go ahead and start treatment. And there's kind of people that are on either side of the fence here. It used to be in the old days that we always would wait. You know, we would sort of make sure somebody made their first couple of appointments, and we would get our genotype. And genotype in my hands, it takes about three to 4 weeks to come back anyway. So it's usually about a month after you've met the patient that you could even get those results. But there's been a study about maybe 3 years ago now by an author named Zolopa, Z-O-L-O-P-A. He's a guy from Stanford. And what they did is they compared starting antiretroviral therapy or antiviral drugs early versus late, and they defined early as within 2 weeks of sort of meeting the patient, and then late being, it ended up being about 40 to 50 days, so about 4 weeks. And it turned out that if the patients were presenting with an opportunistic infection, so they were sick with AIDS or with HIV, that starting early, before you had any other information, was actually better in terms of avoiding serious outcomes than waiting for that 40 days. So there is literature to support what you just did, to start really right away, get somebody on treatment right away. Don't waste any time, because the longer you wait, the more risk there is of something bad happening. But the risk of doing what you did is that if you don't have the genotype back yet, you may have started her on something that she's already resistant to. And so that can have you run into some trouble. For example, if you get your genotype back and she has resistance to, you know, emtricitabine, which is one of the meds that's in Complera, then what you've done is give her just 2 drugs for the first couple of weeks. And that may or may not have some consequences, but it's just a little bit of a risk to starting that. Just so you have an idea of how prevalent resistance is in people that have never been treated, it's on the order of about, you know, less than 10% of people will have a pre-existing mutation or pre-existing resistance to one of those medicines. So there is a little bit of a subtle point where some people feel that if you're going to start somebody on treatment before you know what the genotype is, they tend to pick a more robust regimen, and what I mean by that is something that they're not likely to have resistance to, and that would be a protease inhibitor-based regimen, so something other than Atripla or Complera or Stribild. Those regimens tend to be more pills, so 3 or 4 pills, but it's actually a little bit safer to do, just because of that off chance that you might have started her on something that she's already resistant to. So I think it's okay to go either way. You know, there's not, like I said, there's people on either side of the fence that do different things. But I will say that you really need to pay careful attention to that genotype when it comes back, because you really don't want her to be on a regimen to which she's already resistant, because then you're not giving her 3 fully active drugs. So chances are that your genotype is going to come back and it's going to say that she's sensitive to everything, and then this will all be fine. But what could be a really, really bad situation is if she's already resistant to something that shows up in your genotype and then you put her on the Complera, then you probably would have to switch her right away to a different regimen that's more potent and that has 3 fully active drugs. Does that make sense?
Yes, it does. What was the regimen you recommended? I'm sorry, the more robust one was what?
Yeah, so it's generally regimens that contain a protease inhibitor, and that would be the 2 that we generally use are Reataz or Prazista. Those are drugs that there tends to be really not much resistance at all to those, and so they almost always will work. Those are drugs that are a little harder to take, a little more side effects, and then you also have to boost them with a medicine called ritonavir. And so it adds pills, so it's not anything that's in a single tablet regimen at this point. but it would be a protease inhibitor-based regimen. And I'll try to bring up a slide a little bit later to show you exactly what the regimens look like. I'm trying to remember where my PowerPoint would be. And yeah, I'll show you that a little bit before we're done in the hour. But a protease inhibitor regimen would be a backbone of something like Truvada, which, you know, essentially is what all of our regimens are based on now. Even Complara and Atripla has that 2 nucleotide component into it that's emtricitabine and tenofovir or Truvada. And then building a third agent on top of it, a protease inhibitor-based regimen would be Prazista plus ritonavir or atazanavir plus ritonavir. I know it's confusing to go through all those drugs. Now the other aspects of the case that you asked about, first of all, the boil on the lateral side of her neck. So, you know, I admit you are flying a little bit blind here because your differential diagnosis for what this could be really depends on what her T-cell count is. So if she happens to have a T-cell count below 100, your differential for what can cause a boil on the neck or maybe an abscess or a lymphadenitis is really long. You could have mycobacterial infection, you could have a fungal infection in there, you could have lymphoma. You know, you really got to worry if the T cells are very, very low and she actually has AIDS. But if her T cells turn out to be quite high, then I think, you know, common things are common, and this is going to be Staph aureus or MRSA or something like that. So I agree with your decision to put her on Bactrim. That should really help. If there's anything that needs to be IND'd or lanced, I would definitely try to do that, because the Bactrim, you know, antibiotics only go where the blood flows, and if you have an abscess in there, the antibiotic can only do so much. But that's a good, well-tolerated drug, and it may be that she even needs it as a prophylactic drug if her T cells are less than 200. So that's a good choice. And then your last question about immunization. So a little bit of a complicated issue, but there are generally some immunizations that we really want all of our HIV patients to have or to be immunized against. And they fall into a couple of different categories. The first are the hepatitis viruses. So having hepatitis B, especially in HIV, is a very important consideration, because a lot of the risk factors that get people infected with HIV also can expose them to hepatitis B. For example, men who have sex with men or gay men have a higher incidence of hepatitis B than the general population, as do African immigrants and Asian immigrants, just because of their exposure in childhood. So very important to know if somebody's hepatitis B infected or exposed, and then if they're not, all the guidelines suggest making sure that you vaccinate them against hepatitis B. Hepatitis A is a little bit less of a problem, more of a foodborne illness, and it does not cause chronic hepatitis, but still you should probably get them vaccinated against hepatitis A. Now the problem is that people with HIV infection, especially if they have low T cells and especially if they have high viral loads, respond very poorly to those vaccines. So my practice has generally been to check all their labs up front. So you need to know if they're Hep B infected or not, but then don't try vaccinating them until you've gotten them stabilized, and what I mean by that is their viral load undetectable and their T cells on the way up. Because otherwise you're going to be given a lot of Hep B vaccine, and remember it's a series of 3 shots, and a lot of people won't respond to it if their T cells are low and their viral load's actually high. So I always wait until I've gotten my patient fully undetectable, fully stable, and then kind of think about doing hepatitis vaccination. There's some other vaccines that we use in HIV-infected people that really don't depend as much on the T cell and on the viral load, and that would be an influenza vaccine. We're kind of at the end of influenza season, as well as pneumonia vaccines. And the pneumonia vaccines get a little complicated because there's now 2 of them that are recommended, both the Prevnar, which is the PCV13, and the Pneumovax, which is the PPSV23. They're both recommended in sort of a weird scheme. If the patient has had nothing at all, you should start with the Prevnar and then give the Pneumovax. I think it's at least 2 months later, and then another one in 5 years. And then if they've already had a Pneumovax, then you have to wait, I think, a year until you get the Prevnar. It's a little bit of a complicated scheme. But those are the general ones that I think of. And then you're absolutely right that we should generally avoid live virus vaccines. And that typically means an MMR or a varicella. We don't usually give those. There's been some studies done in people with higher T cells who are stable, you know, T cells in the 600s, and it looks like it's actually okay to use live virus vaccines in people that have fairly good immune systems, but it would be very low down on my list in terms of things to do with your patient. And you definitely don't want to give any yellow fever vaccine to somebody with HIV. So in general, the things that I think about on the first visit are their hepatitis B status, and then can I give them an influenza shot or a pneumonia shot, depending on if they've had one before. And those are okay to give really at any T cell count. And then later on, when they're more stabilized, you have to think about trying to get them immune to hepatitis A and hepatitis B. And then I guess the last one would be tetanus. You know, it's not really a big major problem in people with HIV that get tetanus. You know, tetanus is fairly rare as it is. But pertussis, you know, there probably is a little bit of an increased incidence in people with HIV. So I would make sure that everybody has at least one Tdap vaccine, so they get the tetanus and the pertussis, and then they should have repeat tetanus vaccines, you know, within every 10 years after that. And that's just a part of routine care. Oh, and one final thing with vaccines. So we can't forget that if we find somebody that's young, who's under 26 years of age, we really should try to get them vaccinated for the HPV series. And the reason behind that is because, especially in gay men or men who have sex with men, there's a much higher incidence of anal cancer, and it's all related to HPV. So if you can have an opportunity to vaccinate somebody, even if you can just get 1 or 2 doses into them, it's going to be very helpful to prevent their long-term risk of having anal cancer. And anal cancer is something that's just really hard to screen for, it's hard to diagnose, and it's very hard to treat. It's not like cervical cancer where you can just cut out the cervix. You know, men who have anal cancer that's fairly invasive or advanced, it's a disaster in terms of trying to treat it and preserve their anal sphincter tone. So that's enough on the case. So, is that clear to you, Dr. Webb?
Yes, thank you very much.
Okay.
We made it on the phone, Dr. Echols. We had to just call the clinic.
All right, welcome. Any follow-up questions, Dr. Webb?
There was one question. Go ahead, say your question.
Hello, Dr. Roberts. On the HPV vaccine, I thought there's a certain age that you cannot give it, or it doesn't matter when they have HIV?
Yeah, good question. So I think I said this pretty quickly, but if the patient is over 26 years of age, you can't really get it. I mean, you can give it, but it won't be covered. The indication for the vaccine is only for those that are under 26.
Exactly.
It doesn't make much sense to me. Oh, sorry, go ahead.
I'm sorry, I was just going to say, when you finish with that, I'm sorry, I didn't mean to interrupt you, but I just found one other piece of information. I've been told this patient does have hepatitis C.
Okay. All
so
right.
that may add another wrinkle to her treatment.
Oh, it certainly does. Well, I'm gonna talk in my PowerPoint a little bit about hepatitis C. The overall picture is that hepatitis C would be a more chronic issue for her. I would certainly focus on the HIV first. And it used to be that we'd have to pick our HIV regimen very carefully to make sure that it would be something that didn't interact with hepatitis C drugs. And it turns out that, number one, Complera is a great regimen for somebody with hepatitis C because it doesn't interact very much at all with drugs. And number two, the modern hepatitis C treatments really don't have many drug interactions at all. So there's going to be a lot more available to her to treat her hepatitis C. And then I just want to make sure that that question was answered about the HPV vaccine. You are correct that there are age limits on HPV, which is why it's very important to catch your younger patients and try to get them vaccinated. I believe it's less than 26 years of age that the insurance companies will pay for. It might be a little higher in women, but I'm not sure. I think it's a little bit absurd because in older people, there have been plenty of clinical trials that this vaccine still helps and still works. But it just turns out that that's the label indication by the FDA, and so that's what payers are to pay for.
Thank you.
Any other follow-up questions?
Madu, do you have any questions, Ms. Madu, or any questions about the 2 patients you wanted to talk about?
Yes, I do have 2 cases that I would like to talk to him about.
Okay, why don't we do that now?
Okay. The first patient is a 48-year-old African-American female who presented just for vaginal irritation and discharge. She says she had been HIV positive and diagnosed several years ago, but had not been on medication for like the past 6 months. Last time she said that she was checked for HIV at Thomas Street, she was told her CD4 count was around 30. So I think she said she was diagnosed in 1990. So basically, she has not been on medication for 4 months. She does have an appointment with Legacy to try to get back into care April 21st. So we did a full STD screening for what she came in for. But I did full HIV labs on her. And her HIV CD4 count was 92. Her viral load was 172,000 copies. So she's not on any medication except for the herpes med that I started her on. She has the HIV of 92, so I know at least she's going to be getting Bactrim. I didn't want to start her on a regimen yet because that was the question the student and I were discussing, because she stated she had been on a triplet, Truvada, and Epivir. But the way she was telling me these names, she just said, I don't remember what I was taking, just name a whole bunch of HIV meds. And when I started naming them, she was like, oh, yeah, that sounds familiar, that sounds familiar. So today we did a genotype on her to try to get, something about resistance in case she had been on something, because with her levels, and the other issue, wrinkle is that she has hepatitis B, we just found out. So she just came in today for these results. So what is your suggestion? Because I did send her Bactrim, but as far as starting on HIV meds, do we just wait for the resistance? Do I start her on something baseline? I'm doing a full Hep B panel on her just to get those labs on her and going from there.
All right. Well, it sounds like you got your hands full. So she is going to take a lot of your attention, and there's a lot of little complexities that you alluded to. Dr. Madu, were you on the call in the very beginning of the hour?
I'm a PA. I'm sorry. Go ahead.
Oh, sorry. Ms. Madu, were you on the call at the beginning of the hour? We talked a little bit about resistance testing at the beginning.
No, I'm just getting on. We had a problem, so we had to call from the on the clinic phone, so I can't see your screen or anything. We're nowhere near.
Okay, no problem. I'll just repeat what I said a little bit. It's actually worth repeating. So you, in this case, you did exactly the right thing, which is I would be very concerned, just like you are, about having resistance in this patient. So for a number of reasons. First of all, she said that she was infected since 1990, I think. And if you remember the history of this disease, really effective HIV therapy wasn't developed until 1996. And so anybody that was treated for a little bit before 1996 has actually a chance of being exposed to maybe even a single drug, which we obviously know doesn't work, or maybe a combination of 2 drugs. And in those old days, really what happened is that, the viral load would go down a little bit and then come right back up, and in a lot of cases develop a lot of resistance. So that's one reason I'd be very concerned about resistance in this patient. And secondly, well, there's a couple reasons more, actually. Secondly, she's been off for about 4 months. And anytime you're on and off therapy, that's a high situation for developing resistance, especially if a triplet is part of the mix. And that's because a triplet has 3 drugs in it, and they have different half-lives. You can have 2 parts of the triplet get out of the body right away, and the third part, which is the efavirenz or the Cystiva part, just kind of lingers for about a week or so, and that's a perfect chance for the virus to develop resistance. And then thirdly, I would say just because of the regimen that she'd been on, I mentioned this earlier, protease inhibitor-based regimens tend to be a little more robust and don't develop resistance. And the protease inhibitor regimens I'm referring to are things involving Reataz or Prozista, which are also called darunavir or atazanavir. But she'd been on a triplet, and a triplet is one of those regimens, kind of like Complera, where If you don't take it correctly, you really can develop resistance. So anyway, that's a long way of saying you did exactly the right thing in getting a genotype right away and being concerned about resistance. But I also mentioned earlier in the hour, this is the kind of patient where you really, I mean, something really bad could happen if you just sit around and wait too long. So the one thing you can do while you're waiting is you can start her on a regimen before you have your genotype back, but this is a case where I really would choose a protease inhibitor regimen. And that would be something like Truvada as the backbone, plus Prazista, which is just once a day, plus ritonavir once a day. So it's a multiple pill regimen, but you know, time's wasting and she's got less than 100 T cells. I would consider her like walking in a minefield. You know, she could show up with a fungal infection in her brain or pneumocystis pneumonia or something really, really bad the longer you wait to get her on treatment. Once you get her on a protease inhibitor-based regimen, if you get your genotype back and things look fine and there's no resistance that you can see, you could always switch later on to a more simple regimen like a single tablet regimen. But this is a patient I would worry a lot about. If she comes in with any symptoms, you really have to think critically about a lot of different things it could be, because really she has a very, very weak immune system at this point. She's very immunosuppressed. Finally, the two other issues, the Bactrim, definitely she needs to be on Bactrim, and that's going to be one double-strength tab once a day. Really, I tell patients, you know, keep taking it until I tell you to stop. And you're going to want to keep her on it to protect her against pneumocystis and toxoplasmosis and other things until her T cells have been above 200 for at least 3 months. So just tell her to consider it one of her regular medicines. Not going to be permanent, hopefully, but you know, definitely for the time being she needs to take it. And then finally, the hepatitis B, you definitely do need to work her up for hepatitis B. And you need to keep in mind that whatever regimen you choose for her, you must have part of it that's treating the hepatitis B as well. And so that most of our regimens have that built in anyway, because most of our regimens have Truvada as a backbone. And both parts of Truvada, the M-tricytidine and the tenofovir, are actually both effective against hepatitis B. So it's going to be pretty easy to put something together to treat her Hep B. But then what else should we be thinking about with Hep B? Well, you got to send the advanced kind of Hep B panel, which usually includes a Hep B E antigen and an E antibody, and then a Hep B DNA viral load, basically. Unfortunately, those are pretty expensive tests, but you kind of have to do them in this case. And then you're also going to want to do an ultrasound of her liver, because hepatitis B, even more so than hepatitis C, can cause liver cancer, liver tumors, and then eventually cirrhosis as well. So a lot to think about in this patient. And then in terms of going forward, so you definitely need to follow up your genotype. That's going to be crucial no matter what you do in the short term. Like I said, if you start her on a protease inhibitor-based regimen, you might have the opportunity to switch to something simpler if the genotype looks okay. You certainly want to follow her at least every month and until you feel like her viral load is undetectable, and then I would ease off and go towards about every 3 months. You need to pay very close attention to any symptoms that come up, because, like I said, the differential diagnosis is going to be very big in a patient like this with no immune system. And there's also something called IRIS, or immune reconstitution inflammatory syndrome, where by giving her back an immune system, you might actually cause some symptoms. And you need to warn her about that so that she doesn't kind of run away and never see you again and fall out of care. But things might get worse before they get better. And you just got to get her through that time. And then finally, I would say that you're going to be checking the HIV viral load every month until it's undetectable. That's generally what I do. Hepatitis B viral load is going to take a lot longer to get undetectable. So, and sometimes they get much, much higher. You can show up with, 500 million copies in your Hep B viral load. And it can take up to 18 months or maybe 2 years even for that to become undetectable. And it's a pretty expensive test, so I would probably send a Hep B viral load maybe every 3 to 6 months just to make sure that things are going okay. And then just really, really want to emphasize that she needs to engage in care because she's got AIDS. She has a very high risk of dying if you don't kind of get her right on track within about a year. And finally, I wanted to ask you, what happened with her STD type symptoms, with her vaginitis?
It's weird. She came in with pooling discharge just with walking, and all she had was BV and a bad case of herpes. The RPR is still pending, but I just knew it was going to probably be something more. But I think she had just herpes, a really bad case of herpes.
You know, people with HIV can have really severe manifestations of common diseases. So, you know, you might find something else, but you might not. It just might be, that she's got basically no defenses left, and so the herpes and the BV are just kind of getting way out of control, and she's got no immune system to really help fight it off. So, I would put her on a pretty, I don't know how long you put her on acyclovir for, but I would probably make it a pretty prolonged course. And then a lot of people actually, after they finish an acute course of acyclovir for herpes, they'll leave people on a prophylactic course, which would be 400 milligrams twice a day, just to try to keep it in check and keep it from coming back. Because people can have a lot of outbreaks when they're very immunosuppressed, and really severe ones too.
Yeah, so I did the full Hep B panel, like you mentioned with the viral load, because she does have insurance, and I sent her for a liver ultrasound, so she's going to be, doing that soon. You're right about the acyclovir, because she took just a basic acyclovir that I gave her that day based on her presentation, and she said that there's some improvement, but it's not all gone, and usually with the basic regimen, like TID, it usually, takes care of the outbreak, so now it makes sense why she's still having some symptoms. So I'll go ahead and send her the suppression therapy.
Yeah, I got to think about it. If you like sports metaphors, basically you're helping her with an offense, with some drugs, but she's got no defense. She's got no help in clearing infections like that. So you got to take everything and be a little bit more conservative. I would probably give her, maybe 10 to 14 days of acyclovir at a TID dosing, and then back off to just DID as prophylaxis. Did you say you had a second case as well, Ms. Madhu?
Yes, I do. I have an update from a case we discussed last week, 2 weeks ago, about the patient who I started on Stribild. I had him come back for his 1-month follow-up, and that was the case where the patient was never on HIV meds. He was doing herbals. His viral load initially back in May 2013 was 4,000, but since he hasn't been on meds or anything, because he was worried about the jaundice, it went up to 11,000, and that's the one who we started on Stribild for the first time and counseled him on GI issues. He came back, and his viral load is now 50. He's really happy.
Great. So what was the timing between that 11,000 and down to the 50?
Well, you told him to do a month, so it was 4 weeks.
Okay. So that's a great response. I usually keep in mind the minimum response, the minimum acceptable response is going to be a drop of 1 log per month. And, I'm not very good at math. I don't remember what logs really mean, but it means you're dropping a 0 off, essentially. So from 11,000, the minimum acceptable response would be for him to get to 1,100. And almost everybody, if they're taking their meds, is going to have a response better than that. And then Stribild happens to be one of the regimens where the viral load drops even faster than that in most cases. So, he's almost undetectable. What sometimes happens is that the way the kinetics go with the viral loads, there's a really steep drop in the viral load at the very beginning, and then the drop gets a little the curves get a little more flat. And so sometimes you'll get somebody almost undetectable just on that first month, and then the second month they'll have another viral load like it's 42 or something like that. So I wouldn't be too worried. There's still a tiny little bit of virus left when you see him in another month. But on average, if you get him, you can predict how long it should take for him to get undetectable, and it should go 11,000, 1,100, 110, and then 11. So he should be really undetectable within 3 months. And then the other thing with Stribild, remember that it has that booster in it called cobicistat, and the cobicistat can do funny things to your creatinine level. And so I would make sure that you get a metabolic panel on him, compare his creatinine at baseline before he started to what his creatinine is now. And what you would expect on average is that he should have an increase by 0.1 of his creatinine. And if it gets more of an increase, like 0.2 or more, you got to be a little worried about his kidney function. So you probably, when you get your labs, do you get like an estimated GFR or a creatinine clearance back on your lab report?
Yes. Yes, I do. I'm looking at it right now.
Okay, so he should, in order to start Stribild, you have to have a GFR above 70, and then you want to be really careful if you get anywhere close to 50, if that drops that much. So what numbers do you have?
So when I started him on the Stribild, his GFR was 81.
Okay. And then did you get the follow-up back yet?
Yeah, I did. Let's see. Okay, I'm sorry. So when I started him on it, it was 102. So, wow, it's now 81.
Okay. That's okay. And what are the corresponding creatinine levels?
The creatinine back then was 1.02, and the present creatinine is 1.25. That's
okay.
interesting.
So, yeah, it is. You know, it doesn't really mean that you're hurting his kidney function. It's kind of it's a smokescreen effect. You're just kind of changing the way the creatinine looks on the labs, but I would be careful and just make sure that it stays there or gets a little better. If it heads anywhere further north from 1.25, I would get a little concerned, and we can talk about how to work them up. But, you know, keep in mind, regimens that have tenofovir in it still can cause renal toxicity in about 1% of people. So definitely, that's another thing. While you're seeing him every month, you know, make sure that you're checking UAs on him just to see if he's spilling any glucose or protein, and then obviously follow that creatinine level.
Okay.
Okay.
I definitely
Good
will.
job.
And I have one more patient.
Okay.
It's
Sure.
don't know what to do with her. She's a 41-year-old female, and when she came in, she looks almost 80. No teeth or anything. She came in for this, you know, the usual vaginal discharge, unprotected sex. She was diagnosed with HIV 20 years ago, but she has never taken any meds because she's concerned for her liver. She is an alcoholic. She was high when she came in, crack cocaine. She does IV drug use. So we did labs on her, and unfortunately, or I don't know, but her labs, her CD4 count was 4, basically. CD4 count was a 4. And so I have not been able to get back in touch with her. I think because she came in for vaginal discharge, I treated her, you know, kind of prophylactically, gave her Rocephin 250, gave her azithromycin, Flagyl because of how she was presenting and how she looked. She has not been back for the CD4 count of 4. So I think because she feels better, she doesn't think she needs to come back. And we've been trying to call. I just spoke to one of our social workers. She finally got in touch with her mother in Louisiana, so her mother is going to try to get in touch with her. But the patient's number is, you know, she's not answering and the voicemail has not been set up. And I'm really concerned because she looked almost 40, 50 years older than what she, you know, her birth date is. But now with her CD4 count of 4, never been on medicine. She had lesions and spots all over her body. I tested her for syphilis, and she just came back with herpes. But it's just, she is, you know, she looks broken down, and I'm worried that something might have happened to her because she's not answering any phone calls.
Can you describe the spots a little more for me?
How would I describe them? The spots were, like, her private area just looked like the basic case of herpes, but all over her hands, her palms, her lower legs, it was more like macular dark ring-like lesions. Some had scale, but they were different sizes and shapes. They did not itch. They did not burn. They did not have any kind of symptoms. It was just sores that, you know, looked like they were healed over time. No discharge or anything from it. No, you know, leakage of any fluid. It's just kind of like dark, hyperpigmented macular spots all over her body. And when I saw it on her hands, I was worried about syphilis and things like that. So that's why we did that, and it was negative. I checked hepatitis. Everything was negative. And she's underweight. She's a very small lady. It's just really hard to describe.
Yeah. Well,
my first meeting her.
Yeah, so I think what you're describing is really what end-stage AIDS looks like. And
Oh, wow.
You know, it's amazing that in our country we can still see this. She's going to have a really, really high risk of dying, I'd say, in the next year or so if she doesn't get into care. And so you should be concerned. Some of these cases, she tells me she's alcoholic and, you know, has some social issues and just very suspicious of medical care. And there's only so much that you can do if somebody like that just chooses not to engage at all. But
my worry is she's sexually active, and I asked her about her partner if he's aware of this, and she said all she told him was that she was sick and if he's okay with still being with her. That's all he knows, is that she's sick. No.
Yeah, no, you're absolutely right to be concerned for her life, which is going to end pretty soon, I think, and then also for the transmission risk, because she probably has a very, very high viral load as well if she's end stage. I think, you know, I think what you're seeing on her skin is probably Kaposi sarcoma, or KS, which is, you know, a tumor, a malignancy caused by HHV8, actually, another herpes virus. But it's one of the hallmarks of really, really advanced end-stage AIDS. I wouldn't be surprised at all if she's got one or two other things going on that are just kind of smoldering or subclinical. I wouldn't be surprised if she had MAC infection or CMV or thrush going on. And somebody like that, you just got to do the best you can. And I would offer her treatment if she ever engages again. And she is somebody I would put on a protease inhibitor-based regimen, or maybe Stribild or something if you think it's going to work at all. But she's probably going to have a catastrophic opportunistic infection very soon and end up in a hospital. But you're right. Your instincts are absolutely right. You know, some people that have it sounds like she also has what's called AIDS wasting syndrome, where people, you know, in Africa it was originally described as Slim's disease because people just started wasting away and becoming very cachectic, and that's just from having very high viral load and no ability to fight it, and plus or minus any other opportunistic infection. So there is some evidence that, you know, at the very least, if you gave somebody like that Bactrim, that it might help them a little bit too. So I would have a real low threshold of giving her Bactrim if she does show up again. You know, I think otherwise you need to reach out and get some help from social workers that can really track her down and get her engaged in care.
Okay,
That's a really tough one, though. It sounds like you're getting a lot of really good experience, though, and I'm impressed the way you're presenting cases. You know, you're sounding more and more like an expert, so good job.
And I want to commend Ms. Madu. She's doing everything, you know, she knows how to do it more, and reaching out to the right people and not hesitant. Sometimes when we get this information, when we get patients that have multiple medical problems and they have addictions, we have to be very quick. We can't procrastinate, and that's one thing Ms. Madu does. She reaches out like immediately. The patient could still be in the exam room, and she'll reach out and let us know. And that's what I want to remind the providers, that if you get patients like this or any patient with chronic care issues, please reach out right away, because if we can't get back in touch with them, we have someone here. Ms. Cox is the person that calls them, sends out letters. She sends them out certified to their address and continues to call them. And if needed, if we feel an emergency, we can always send a police out to their address if we have the correct address. So I wanted to say that.
Well, I have a genotype.
Oh, go ahead.
I was saying I do have a genotype, but will it matter with her CD4 count of 4 at this point? Because there are some resistance on here, but I don't think it would, you know, I think anything would help.
No, I mean, you still should give her something that's going to be effective. So what are the mutations that show up on the genotype?
Atazanavir says resistance possible. Viricept, okay, so that's Nureataz resistance, Viricept resistance, and Norvir resistance.
Okay, interesting. So maybe Stribild would be a good regimen for her. it's interesting that she's got protease inhibitor resistance, so it makes me think that maybe she was on some meds some point in the past. But you know, Stribild 1 pill once a day, that might be something that could help her. I would also say that, you know, the Norvir resistance that she has is okay. You're not using Norvir as a protease inhibitor. You're using it as a booster in most cases. So you could still use like a Prozista and Norvir regimen for her. But I would say go with something like Stribild just to try to get her some benefit if she re-engages. And I also just want to commend you too. These are very, very difficult patients to take care of. You know, incredibly complicated. Walking into your office with a problem list of 6 or 7 things, and if your clinic is like mine, your administrator is trying to get you to see him in 15 minutes. And I just really commend you for doing it. It's incredibly rewarding. You know, you can't save everybody, but often if you see somebody like that, you can get them on track. And there's nothing really more rewarding in my career than to take somebody with terminal AIDS like that, and if you can engage with them enough to get them better, the before and after pictures are just amazing. You can take somebody that looks like a skeleton and get them back to health, and then you have an incredible bond with that patient, really, from saving their life. You know, in outpatient medicine, we don't get many chances to sort of swoop in and be the hero and save people's lives, but this is really one chance that you do have. And it's not going to work on everybody if they don't want to take care of themselves, but keep doing it long enough and you certainly will find some people like that. All right, any more points of discussion? I've got about 10 minutes just to go through some slides. Dr. Eccles?
Yes, sir. You can go forward.
Okay.
Can you hear me? Okay.
Right, I can. Let me try to share my PowerPoint here. There we go. Okay. So can you all see that okay?
Yes, sir.
Okay. So I'm going to go through hepatitis really quickly, and actually, you know what? I think I might. No, we'll do this. We'll go ahead with hepatitis. So I've talked to you about epidemiology and testing about hepatitis, but I want to go through a little more of the natural history of what happens with hep C, because it's a very, very different disease than HIV. So we generally think of everybody, almost everybody with HIV, within 10 years, they're going to go on to develop AIDS if you don't do anything. And it's actually very different with hepatitis C. Not everybody with hep C goes on to develop liver disease right away. And some people actually live their whole lives and die of something else. So it's not like everybody with hep C needs to be treated right away the way it happens with HIV. This scheme is kind of how I think of patients through their time, their lifespan, basically. I'm trying to get this slide to advance. There we go. Okay. And what happens is that after people are exposed and have some level of acute hepatitis, about 15, and actually more recent studies have put this number more like 25%, actually get over it on their own, and they have resolution of their hep C. And so all they'll have is a hep C antibody that's positive, but if you look for the hep C viral load, it'll be negative. And those people really don't have hepatitis. They've been exposed, but they've gotten over it. Turns out that it's probably a genetic reason that some people just have better immune systems at fighting off hepatitis C. But in any case, about 75 to 85% will go on to chronic infection, and those are the people that you need to worry about more. But then this, let me try to get a little pen here so I can circle. There we go. So this little arrow here is really the most important one. It's the hardest job for you as a clinician to figure out who is going to go on to cirrhosis. And you can see here that it ends up being about 20 to 30%, but it takes about 20 to 30 years. And so we spend a lot of our time in hepatitis C trying to figure out, living on this arrow, basically, seeing if somebody just has early chronic infection or if it's gone on to develop cirrhosis. And there's lots of different ways, lots of different places to find information. The gold standard really is to do a liver biopsy, but that's pretty invasive and it's hard to get it paid for, and it's really becoming kind of a thing of the past because we have other methods to try to tell who is on that road down to cirrhosis. Once people develop cirrhosis, all kinds of bad things happen. This is a constant rate per year of about 3% per year that develop end-stage liver disease where the liver just fails, either through esophageal varices or ascites or encephalopathy or hepatorenal syndrome or coagulopathy, all kinds of bad things. It's a terrible way to die if you've ever spent time in the hospital with people like this. And then the other thing that happens at a constant rate is hepatocellular carcinoma. at a constant rate of 4% per year. And honestly, when people get to this point, they need a hepatologist, first of all. You know, it's kind of more than I can handle in clinic. And the ultimate treatment is either they get a transplant or they die. So really, we want to spend our time over back here on this arrow, you know, treating the people that need to be treated before they get to cirrhosis. This whole process is accelerated by hepatitis B co-infection, by ongoing alcohol use of anything more than about 20 grams per day for an average man, which I think is about more than a drink a day, which is why we don't recommend any alcohol at all, because if you tell somebody it's okay to have one drink, they'll probably have 3 or 4. And then also in people with HIV infection, the whole process is accelerated as well. The general timeline is about 30 years, so the people we're most worried about are those that were infected in the 80s and 90s. I see some young people that, you know, injection drug users that were infected a couple of years ago, and I'm honestly not too worried about them because it takes so long for their hep C to really cause the damage to their liver. A lot of people want to be treated right away because they know the treatments are getting better, but, you know, I really think focusing on people that have been infected for a long time is the best bang for the buck. So the way we think about that arrow that goes between just chronic infection and cirrhosis is that the liver is gradually going through different stages of fibrosis. And fibrosis just means scarring, basically. And it all has to do with this little area right here called the portal triad. I guess you can't really see me. I'll draw an arrow there. So the portal triad is where you have the portal vein coming in, there's a hepatic artery, and then a little bile canaliculi there as well. And this gray area right around the portal triad, as you can see, kind of grows as you go through stage 1 and then stage 2. And this is just scar tissue being laid down by these cells called stellate cells in the liver. They're kind of like macrophages. And eventually when you get to stage 4, there's so much scar that the liver tissue is really replaced by scar and fat. And so the liver function just doesn't really happen anymore. And this is what information we get from the biopsy, but there's actually other ways that we can get this information as well. This is what it looks like under the microscope. There's a couple different staging systems, but the most common one we use is called METAVIR, and it just goes 0 for a very healthy liver that's mostly pink, you know, nice good pink liver tissue. And then when you get to stage 1 and 2 and 3 and 4, what you're seeing here is the blue is collagen or fibrous tissue or scar tissue. So the scar tissue eventually replaces a lot of the liver as well. And then the white in these stains is fat or fatty liver, or it's called steatosis or steatohepatitis. So you're having through time, and this whole process takes, you know, 20 to 30 years. So each stage, I would say it takes an average of 3 to 5 years before somebody jumps to the next stage. So if you biopsy somebody or you get some information that they're a stage 1, you can think, well, 5 years till they're stage 2, 5 years till they're stage 3. So that person has 10 years before they're going to run into trouble. But gradually the liver tissue is just literally replaced by fatty tissue and scar. And so eventually when you're on the right here, there's not much liver tissue left, and it really can't work all that well. There's a lot of other ways to try to predict how much scar there is short of a liver biopsy. And here's a list of several of them. The top 3 things are really, the top 4 things actually are just blood tests. The top 2, the OPRI and the FIB4, being totally cheap because you're doing liver panels and CBCs on almost all your patients, and all you have to do is figure out how to calculate it. The OPRI is the most simple because it just takes an AST level and a platelet level, and it spits out a number. And then the FIB4 is a little more complicated. It's got a little square root there, which I definitely can't do in my head. But both of these are fairly accurate, you know, talking about sensitivity and specificity on the order of like 70 to 80% or so. And then HALT-C is just kind of a big cohort study where you can plug in some numbers and it'll give you some predictors of how advanced people's liver disease is. And FibroSure is a little bit more expensive. It's a blood test that actually measures many things, beta-2 microglobulin and platelets and INR and everything, and then the LabCorp does this. It's about $150 or $200. They'll spit you out a fibrosis level, grade 0 through 4. And so all these things are kind of, you know, easy, cheap ways to tell if somebody has advanced fibrosis. I'd say the OPRI is probably the cheapest and easiest, but even cheaper and easier than that is just to look at the patient's platelet count. Because if the platelets are below 150, you can pretty much tell that they already have cirrhosis. So if you're looking at these patients, that would be the patient like the red flag. I think of a platelet count below 150 in the same way I think of a CD4 cell count below 200. That's a patient that's really in trouble. These bottom two things are sort of more fancy imaging studies. There's something called FibroScan, which is an augmented ultrasound test, where they actually send kind of a shock wave through the liver, and it tells you how elastic the liver is, and that's a brand new technology that's not all that available. I think there's only one scanner in each major U.S. city at this point, and it's pretty expensive, and you can't even really bill for it until next year probably. And then magnetic resonance elastography is also kind of very, very expensive, but in research centers they use that to look at the liver. And what I said before, basically all the normal functions of the liver just break down. So the liver, remember what it does from your training. It basically is filtering and processing all the nutrients that go from the gut through the portal vein. It produces a lot of very important proteins, including the proteins that clot your blood and all of your albumin that's in your blood. It detoxifies a lot of waste products, especially things that have ammonia in it, and any drugs that you take as well. And then it processes bile. And when those things break down and the liver gets cirrhotic here, which is kind of a gross beef jerky looking liver there, you get all the consequences. So the portal hypertension is because the blood can't really flow through the liver and you develop ascites. Malnutrition, people's albumin starts to drop. I didn't put it on here, but coagulopathy, their INR is going to start to creep up above 1 and they'll start to bleed more easily. All these things as a direct result of the normal physiology of the liver. I'm going to skip through this. Tons of statistics about how bad things are with hepatitis C. Most liver transplants in our country are caused by hepatitis C, and there's probably about 16 to 20,000 people a year that die of hep C, and it's going to peak at around the year 2030, we think. Let me skip through that a little bit more, just to have the idea that the portal vein is a source of a lot of the complications from hepatitis C. This is the portal vein coming in, through the gut. Basically, all of your gut blood flow goes to the liver, and when that can't go because the liver gets too full of scar, the blood flow just sort of backs up. And if you just look at the splenic vein here, which I'm going to sort of draw a little thing there, the splenic vein, when the blood flow goes backwards, the spleen just starts to grow and get engorged in blood. And so if you have a spleen that's very large on your ultrasound that you send, that's another sign that there's a cirrhosis going on. Another example is that you can have varices in the esophagus, which are just big blood vessels from the blood going backwards, basically varices in the stomach that are gastric varices. And these are actually, by the way, probably the most lethal complication of hep C, because about 30 to 40% of these, if they bleed, it's fatal. So big, giant veins in your esophagus, if they open up, 30 to 40% of the time, the person's going to die right away. Ascites is kind of the opposite problem with fluid seeping out into the belly. And then hepatic encephalopathy is when the liver can't really detoxify the bile or the ammonia, and eventually hepatic coma is kind of one of the end results. Like I said, this is going to probably peak in terms of mortality at the year 2030 if we don't do anything about it. So a lot of people like me are very interested in getting a lot more people treated for their hep C. And then I'm just going to kind of close with this because it's interesting for people like you that are starting to take care of HIV. HIV mortality has been falling because our treatments have gotten a lot better. And it looks like since 2007 or so, there's been more people in our country that have died of hepatitis C than have died of HIV-related causes. So that's kind of a product of both HIV therapy becoming better and hep C becoming more prevalent. It turns out most people in our country that have hep C are in their 50s and 60s, and they were probably infected a long time ago. So there's a huge cohort of people that have had hepatitis C for many years, up to 20 to 30 years, and those are the people that are going to start showing up in hospitals. So I'll just summarize here, and then it looks like I still have more time, maybe next session, to do more on hep C treatment. But the complications can take up to 30 years. So somebody who's just been diagnosed, the first thing you need to do is try to find out where that person is in terms of that spectrum of stage 0 through 4 liver fibrosis. There's things you can tell them right away after they're diagnosed. You don't have to jump in and treat everybody, but you can certainly tell people to stop drinking so much alcohol. And again, we try to tell people don't drink at all, knowing that they're going to have one drink once in a while. If you say it's okay to have 1 or 2 drinks, it's just going to turn into 3 or 4. We definitely want to make sure people are immune to hepatitis A and B. We definitely want to tell them to stop eating so much fat, because having high BMI can predispose you to fatty liver, and that actually makes the liver worse. HIV, obviously want to get that treated, because untreated HIV especially can accelerate the whole process. Once the cirrhosis happens, there's very high mortality from liver failure, which we call decompensation, as well as hepatocellular carcinoma, which is a very difficult cancer to treat. And it's thought that there's a large burden of Hep C-related death in the next 10 to 20 years, and it's already more than HIV ever since 2007. Okay, I just felt like I wanted to show you one more slide because I mentioned I was going to talk about syphilis just a little bit in my last minute. So it has to do with classifying syphilis. Here we go. Okay. So this is a really complicated slide, and I'll leave it up here for a while, but this is what I go through every time I hear the word syphilis in a patient. So you really need to classify whether this person has primary syphilis or secondary syphilis or latent syphilis, and if they have latent, you need to know if it's early latent or late latent. And what you can see here is that people can go sort of back and forth between different phases. Most people will have a chancre, which is a painless ulcerative lesion, and it can be really anywhere exposure occurs, whether it's in the genitals or the rectal area, or even in the mouth. Most people will go on to a latent phase, 75%, without any secondary syphilis, but some people go on and have secondary syphilis, which is really kind of a systemic febrile illness with rash and fever and headache, and that's where you have the lesions on the palms and the soles. And then most people go on to what's called latent syphilis, where there aren't any symptoms at all. You'll just pick up a positive RPR or VDRL or syphilis antibody if you have that test. And then, like I said, once they're at latent, they don't have any symptoms at all, but you really need to know if it's early or late, and you define that as greater or less than 1 year. Or if you don't know, you have to call it latent syphilis of unknown duration, and there's a specific treatment implication for that. Rarely do people go on to what's called tertiary syphilis, but that's when we see things like gumma and bone disease and aortitis and cardiac disease and something called dorsalis pedis or nerve disease. Let me just show you the treatment regimens because they really depend on what stage you're at. So here you go. So you can divide this into, on the top, primary, secondary, and early latent syphilis all are bunched together, and they're all the same treatment, which is a single shot of benzathine penicillin, 2.4 million units, IM times 1. So if you find somebody with secondary syphilis, it can be a dramatic presentation with a rash and headache and fever. All you need to do is just give them a single shot of penicillin and you've cured them. Early latent syphilis, if you know that somebody's had a negative RPR within a year and you can time it as less than a year, it's the same thing. It's a single 2.4 million unit shot of penicillin. Doxycycline is an alternative. It's been studied a lot less, so we would always prefer to use penicillin. And the real tough situation, which knowing your clinic or you might even see, would be a pregnant woman with syphilis who's allergic to penicillin. And in that case, you really have to desensitize her because you can't use doxycycline in pregnancy. If you're in this middle stripe here, it's a different treatment. So that would be late latent syphilis for more than a year, latent of unknown duration, or what you just call late syphilis, and that takes 3 shots separated by a week. So benzathine penicillin, 2.4 million units again, once a week times 3. Or if you're going to treat with doxycycline, if they're truly penicillin allergic, it's got to be a 21-day course. And then on the bottom here, if you're getting into neurosyphilis, which would be syphilis with any neurologic symptoms, or if somebody did a lumbar puncture, it's a different treatment. You got to put them in the hospital and give them IV penicillin. You can do IM shots every day for 14 days. Most people don't like that. So that's all I wanted to say about syphilis, and I will close unless there's any additional last-minute questions.
Can you go over the difference between the early latent and the late, which the symptom that patients presenting? Because sometimes we're screening and we're getting positive RPRs back, and they're not even aware. They don't have a chancre. They don't even have a rash. They were not even aware. So we're treating them like, okay, latent unknown with 3 shots.
I don't know what you're saying.
Can you hear me? Okay.
I'm not hearing him.
Okay. Okay. I'm sorry, Dr. Rames. I think we lost you. Can you hear us? Okay.
I can hear
okay,
you.
I can hear you
you
now.
hear me?
Yeah,
Now we
I can hear you now.
Now we can hear him.
Okay, sorry, I don't know what happened there. So the answer to your question is that by definition, latent syphilis does not have any symptoms. And you're exactly right that if you can't put the timing less than 1 year, that is latent syphilis of unknown duration, and you have to treat them with 3 shots. There's really no other choice. Chances are that they have had it for more than a year. You know, they got infected in their 20s and nobody treated them, and then they've just been hanging out, and you just happen to send a screening test, in which case you really do need to treat them with 3 shots. I would mention there is a small chance of having a false positive RPR. So usually what happens is your lab will do a sort of a confirmatory test, or like a TPPA or something like that. And that gets tricky because if the TPPA is negative, then they actually probably have a false positive RPR. But if the TPPA is positive, that's real, and then you got to work on the timing and whether it's within a year or not.
Okay. We had one of those, and it turned out to be mono. So is mono a cause of false positive RPR? Because I think we scared a young lady and her father because the RPR was positive. We did the VDRL, and the confirmation was negative. And she had some occipital lymphadenopathy, and it turned out mono was positive. So is that why?
You know, I haven't heard mono as a cause of false positive RPRs, but what falls in the categories that does cause false positive RPRs are all kinds of autoimmune type diseases like lupus. Sometimes even pregnancy can cause a false positive RPR, lupus anticoagulant, and that kind of stuff. So there's probably something about mono that is sort of in that category. You know, when you send a monospot, what it is it's really just a heterophile antibody, which is an indicator that the immune system is going crazy and causing weird stuff to happen. So it makes sense to me. I just haven't heard that specific association. All right. Well, I'm over time. I'm glad you guys have all stayed on. I'm happy to see that you guys are getting more experience and you're doing great things for your patients. Dr. Echols, I think we're going to do another one in about 2 weeks on the 24th.
Yes. Yes,
sir.
Sound
okay to you?
Yes.
Okay, so we'll see you.
Yeah, we're definitely getting more patients, and so we really, really appreciate you coming on, helping us. So we definitely we'll schedule 2 weeks from now.
Okay, sounds great, and I really like how you guys have the cases you're willing to discuss. It makes it, I think, much more useful for everybody. So good job.
Okay. Well, thank you so much. See you next 2 weeks.
Okay.
2 weeks. Bye-bye.
All right. Bye, everyone. See you in 2 weeks.
Bye.
Bye.
Bye. Okay, I'm leaving there, man.